Skin is not intact, and tissue is not muscle tissue, but part of it is neural tissue for the spine. Okay, so it's like there's an ulcer, there's a wound. Okay, so mothers will come complaining of a wound at the back. Be careful. It could be spinal. Okay. Then that is spinal bifida. To the head, you can have these defects. Anencephaly. Anencephaly. You can see anencephaly. This is anencephaly. Okay? Involving only the brain, or rather the skull and the brain. Okay? Anencephaly. The baby can be born with a sign of life or not. What do you think you can do if, for instance, you happen to deliver such a baby? I'm not saying you delivering. By delivering, you are a health personnel, you are a doctor, you are this mother who has just delivered this baby. Yeah. So anyway, when such a baby is born, the baby should be taken to what we call the neonatal intensive care unit. It's an ICU for babies, for newly born babies. That's where you transfer the baby to. Now there in NICU, if you happen to work there, of course, there are protocols. Every hospital has protocols. Okay? Of course, guided, if it's a government system, guided by the Ministry of Health and so on. So these guidelines, what you should do when such a baby has been brought to you by NICU, what you should do. So there are steps. If you go to another country, they may manage such babies differently from here, for instance. There are two general principles. Some, they keep the baby and feed it. Okay, so they'll be providing food for the baby. You feed the baby. Of course, you don't expect this baby to swallow because the swallowing response is not there. There is no brain. You get the point? So no brain, no swallowing reflex. So it can't swallow. So you have to push in a tube through the mouth to the stomach and feed it via the tube. NG tube, what we call the nasogastric tube. So some feed like that, others just leave it for nature to take its course. Yes. Those who feed, basically they feed so that they keep the baby alive for a few days. Of course, it's incompatible with life. At some stage, the baby will die. But they feed it so that they keep it alive to help with the grieving for the mother. Okay? The mother is grieving. Okay, the mother will be able to see this baby and so on, can even name it. Relatives can come and see the baby and so on. So they just help with the grieving period. Get the point, so they understand. Okay? Because some may think that it's witchcraft. No, it's not witchcraft. Okay? Remember that this woman is going to go back to her community. Okay? When she goes back there, neighbors. She has come back with no child. But she was pregnant. Very important. So neighbors will not understand, especially if it's in the villages. Okay? And so on and so forth. So to just help with the grieving, relatives, neighbors, what they can come and see the baby. Okay? help with the grieving. And then you are explaining the condition to them, how it comes about, and how to prevent it, the recurrence rate, and so on. Okay? Because again, there's potential that the next pregnancy can occur, such a thing can occur. Okay, so how to prevent it, and so on. That's about those who feed. Those who don't feed, the general principle is that why should we feed and prolong the life a bit longer and make the baby suffer for the fact that we know that the baby is going to die? You get the point? Yeah. It's like some laws in certain countries when someone has cancer at the terminal end there. Okay? Some countries, allow that the patient can request to be killed instead of, suffering the way he or she suffered. You get the point? I've never heard of that.
Yeah.
Yeah, there are some countries which allow you can request that the doctors kill you. It's better to be killed than to suffer for one more year. And so that's the principle. So even here, that's what the thinking is. Okay? So some feed, some don't. But of course, it's incompatible. The best is to screen. Okay? In the antenatal period, screen the pregnancies. Okay? You can screen. There are a number of screening tests you can do. Okay? One of them, you can do serum alpha-fetoprotein. Serum alpha-fetoprotein elevated. If it's elevated, it's a sign of neurotube defect. Of course, it can be other issues, but neurotube defects will be there. Okay? Do a scan, you can do an obstetric scan, and a normal, fetal anomaly scan. Between 18 to 21 weeks, you do that scan. Okay, if it shows there's an encephaly, you give options to the woman. Okay? It's not you to decide to say we are going to terminate this pregnancy. It's not you as a doctor. Professionally, you give advice on the options available. What are the options available? Two options. One, to terminate. Two, to keep the pregnancy until the woman delivers. You get the point? Why am I saying so? Because some are devout in terms of religious beliefs. Okay, they may not accept termination. For instance, the Catholics, okay, may not, because someone believes in certain doctrines and so on. Get the point? So certain religious beliefs may not allow you to terminate that pregnancy. And so they would rather keep the pregnancy. But you warn them of the consequences. They must be aware of the consequences afterwards. This is a pregnancy that has potential to be prolonged beyond the expected date. It can go into 10 months, for instance, because labor will fail to be initiated. For labor to initiate, it requires that the fetus should have a pituitary gland. Now, this baby has no pituitary gland, so no hormones from there to initiate labor. And so, labor may be prolonged, and it may require induction for you to deliver it. You get the point? The other consequences could be that if labor starts, it may fail to progress, because for labor to normally progress, it requires the head to compress on the cervix. Now this has no head, so no head to compress on the cervix, and so the cervix will not dilate. You get the point? And then the other consequence could be that delivery of the shoulders could be difficult in this group. Okay, at the time of vaginal delivery, shoulders may be difficult to be delivered. Okay, and so you may require even cesarean section for such a baby. You get the point? So the earlier, the better to terminate in that case. So each has advantages and disadvantages, of course. Should you terminate or should you let nature take its course? Okay? So you give them options. Don't just be, because there's this anti-self scar. So, you know what I mean? You just need to terminate. You know, obstetrics is very nice. Obstetrics, we wait like, you know, like you are selling some things. Okay? So you don't make people, you know, buy, you just buy an iPhone 13. You just buy a Samsung. No. People will come, they'll see the stuff, okay, and then they will decide on their own. Okay? If they need help, you help in terms of advantages and disadvantages of the things you are selling. Even in obstetrics, that's the principle we follow. The woman comes, like in this case, you identify the problem with a clear diagnosis, you give options. And you explain, of course, for each option. And then the woman will decide on herself which route to take. It's not you to decide for her. You only come in if the life of the woman is threatened. That's why now you come in to decide. To say, it's this route that we need to take. For instance, if there's a rupture of the ectopic pregnancy, it's a threat to the mother's life. So, your advice is to operate immediately without delay. Because should we delay, the woman will die. That's the only part you can. If life is threatened, life of the mother especially, followed by life of the baby, fetus. Okay, otherwise, if there's no threat to life, you let them decide on their own. Yes.
What are the chances of surviving for a child with spine defect? Especially, maybe you can talk about
the chances of survival for these babies?
So babies with spine.
Spinal bifida. Yeah. They survive. Of course, they survive. Most of them survive because it's the spinal cord which is possibly that you're going to get worried of. But there are orthopedic surgeons that are able to correct the defect. Okay, so you refer such babies with the spinal bifida to orthopedic surgeons, and then they will correct the defects. The orthospine, orthopedic spinal surgeons, okay? And they will correct the defect, and the baby will be okay. Most of them survive. Okay. Now there is a combination here. We can see on B. It's a combination of anencephaly and spinal bifida. So we call this combination cranial rachis.
Cranial rachis.
So that is cranial rachis. Okay? You can see these babies. These are real pictures. 19th August 2009. That baby was born at UTH. Okay? You can see it.
There's no hair.
Anencephaly.
Then there's hair.
See, at the back, it's actually a combination. It's the same baby, but cranial rachis. It's a combination of spinal bifida with anencephaly. So cranial rachis.
And that's a lot of hair. Yes.
Okay. You can have the same principle behind the vertebra, the spine, you can have the same principle on the head. The occipital bone, the squamous part, squamous occipital bone may fail to develop. And if it fails, there will be a space for herniation of the meninges and the brain, including the ventricles inside. They can herniate through that space. So we can see in the first picture here, only the meninges have protruded. Only the meninges have protruded. So we call that meningocele. So now this is cranium bifida. The other one was spinal bifida. Okay? Spinal bifida can come with meningocele. If it's only meninges protruding into it, it can come with meningomyocele. Myocele now to do with the spinal cord. Okay? But in this case, cranium bifida can come with meningocele, where only the meninges are protruding, the brain is still inside. Depending on the defect size, the size of the defect. Is it small? Is it too big? You get the point. If it's small, it will only allow meninges to pass. The brain tissue will be inside. The bigger it is going to allow now even the brain tissue to protrude through it. And so we call this one meningoencephalocele. So cranium bifida with meningoencephalocele. Then the larger it is, you can see now there, even the ventricle. The ventricle has also protruded. So now it's a combination we call meningohydroencephalocele. So cranium bifida with meningohydroencephalocele. So you can see that. Okay? So it depends with the size of the defect. Yes. There's a question here that do you think it's a good idea to show the mother such a baby or to hide the baby from her?
No. Don't hide.
So professionally, you should show the mother the baby.
Yes.
Get it? Okay? It will be very unprofessional for you to hide the baby from the mother. Okay? One, for various reasons. One is the grieving period. Those stages, remember? In psychology, you have done it. From denial to acceptance. It requires that you show the baby to the mother. Okay? And explain the reason why the baby is like that. What could be the explanation to the cause of the difference. Okay? That is very important. Now, if you hide, she won't know how the baby appears. She won't know, and she may actually accuse you of, stealing the baby, or swapping the baby with another baby. Yeah. So professionally, you just need to show the baby to the mother. Okay, it's very important. It's part of management. Okay, so don't hide the things for patients. And you can be sued, remember? You can be sued that you gave the mother another baby which has defects. And you have no evidence now. And remember, when things happen like that, mother is always right. You go down the drain. They'll make sure you go down. They'll sue you, HPCZ will come, revoke your license. And you go back to the village. Yeah, but it's now you to foot the bill. You see now? Yes. So why should you reach in those stages? So it's very important
Two
You
heads.
revoke your license, you stop practicing medicine. It means your entire 6 years of wasted goes in the drain. Go back to the village. Or maybe you change career. Go and do purchasing and supply. All right, so we can see this is a real picture, occipital meningoencephalocele. Okay. Now, when a baby is born like this, you may not know the contents inside until you do imaging studies, until you do a CT scan or MRI scan of the brain. That's when now you'll be able to tell, are there only meninges inside, or there's also brain tissue inside, or there are also ventricles inside. Get the point. Okay, until you do a CT scan, MRI scan of the brain, you won't know. And that helps with management. How are you going to reduce? Because this is like a hernia. It's basically a hernia. So how are you going to reduce this hernia back into the scalp and seal the defect? So again, neurosurgeons you refer such to the neurosurgeons. Okay, so we have come to the end of 30 to 50.
No, I don't know currently.
And
But
neurochip. Basically, we have also described neurochip information.
the band that means.
That's neurochip. The paper I was holding here showing you how the neurochip forms. We are done with the neurochip. Also, neurochip information. So for you now, it's just to go and
The one
start
like
it.
the white was on the
So in the separate lecture for neurochip formation, there will be some fractures being mentioned, cephalic fracture, cervical fracture, okay, the different parts of the brain, the prosencephalon, which we did last time, remember? Prosencephalon, mesencephalon, rhomboencephalon, okay, and the various components, cerebrum, okay, coming from the telencephalon, we have the diencephalon, okay, the mesencephalon having basically the midbrain and the subsequent structures for the midbrain. The rhomboencephalon for the bones, the dalla oblongata, and cerebellum. Okay, so those you just want to polish up. So the only thing remaining now is the pituitary gland. In 10 minutes, pituitary gland development.
It's Unza. The Unza you chose. Dumas. The Unza you chose.
So, pituitary gland development.
Hypophysis cerebri.
The pituitary gland is a very important gland, which, of course, if you remember from your biology, you used to call it master's gland, isn't it? Yes. Yeah, master's gland. Why were we calling it like that? Because there are a number of hormones which come from this pituitary gland, which go to control other glands in the body, other endocrine glands in the body. Okay? So it sits in a structure we call the sella tesca of the spinal bone. Of course, you remember that from your skeleton. Okay? Now, the pituitary gland is connected to the brain, specifically the hypothalamus. What do you know? Specifically to the hypothalamus. So you can see the connection between the pituitary and the hypothalamus. Okay, the hypothalamus is the part just below there where it says hypothalamic sulcus. That hypothalamic sulcus is separating the hypothalamus below from the thalamus above. Okay, that sulcus. Sulcus is a groove, like a demarcation, a groove. Okay. So now we can see that the pituitary gland is connected to the hypothalamus. This connection which is labeled pituitary stalk or invertebral. This is a bridge between the nervous system and the endocrine system. It's a bridge between the nervous system and the endocrine system. In the same way, we have the Luangwa Bridge, being a bridge between Lusaka and Eastern Province. If you break that bridge, you will be unable to go to Chipata, isn't it? Yes, if you are using the road. So, even here, if you break this bridge here, then there will be no connection between the nervous and the endocrine system. These two systems, remember, they are the ones which coordinate the rest of the systems in the body to make an organism working as a unit, as one. The muscular system, all those systems. For them to work as a human being, you require this connection. The nervous system and the endocrine system. This bridge is very important. Okay, now the pituitary gland is divided. It's a two gland in one. It's also called hypophysis cerebri. It's a two gland in one. Okay, anterior pituitary gland, which we call in histology adenohypophysis, and posterior pituitary gland, which we call neurohypophysis in histology. These are the two components of the pituitary gland. It's a two gland in one. And why is it a two gland in one? It's because of its development, which we are going to talk about. Development of the pituitary gland will help you understand why the pituitary gland is a two gland in one. Okay, because these two components, they come from separate sources, two different sources, okay, to form one gland. Now, further, adenohypophysis. Adenohypophysis is subdivided. Okay, we have what we call the pars distalis. The pars distalis, which is a major component of the anterior pituitary. Pars distalis. Then we have the pars intermedia. Pars intermedia, and we have what we call the pars tubularis. Pars tubularis or invertebralis, if you want. Pars invertebralis. Okay, so those are the components for the adenohypophysis. Pars distalis, in gross anatomy, it will be the anterior lobe. In gross anatomy, that's the anterior lobe of the pituitary. The pituitary gland has three lobes. You have the anterior, middle, posterior. The anterior, pars distalis. The middle, pars intermedia. And the posterior, the pars nervosa, which is part of the posterior pituitary. Okay? So posterior pituitary has two components. We have the neurostalk, or also called the hypophyseal stalk, or invertebral. Then there is a pars nervosa. Pars nervosa. Okay, the posterior lobe. So these are the components. Now let me show you these components. So you can see here this one. So this bulge anterior, that bulge anterior, that's the pars distalis. Pars distalis. You can see it's labeled pars distalis. Then there is a pars intermedia. A pars intermedia, just after this cleft, there's a pars intermedia. So after the cleft, there's a pars intermedia. That's the middle. And then we can see the pars invertebralis or pars tubularis surrounding the neurostalk. Surrounding the neurostalk or pituitary stalk. So the orange colored part is the anterior pituitary. That's the anterior pituitary. And then posteriorly, we can see the yellow color. Is it yellow or white? Yellow color. it's a continuation of the hypothalamus, showing you that it's part of the brain tissue. So the posterior pituitary is part of the brain tissue. No wonder it's called neurohypophysis. Neuro, to show you that it's part of the nervous system. The hormones which come from the posterior pituitary, they don't really come from the posterior pituitary. They come from the hypothalamus. They come from the hypothalamus. We can see those tracts, supraoptical hypophyseal tract, you can see there. So those tracts, they are carrying hormones to the posterior pituitary from the hypothalamus. What are these hormones? Oxytocin and ADH, antidiuretic hormone, or arginine vasopressin. So those are the two hormones which come from the hypothalamus. They are going to be stored in the posterior pituitary for later release. So if someone asks you what is the source of oxytocin or source of ADH, and then there will be options there. A is A, B, okay? So don't go for the posterior pituitary, because that would be wrong. Yes, we know that the final release is from the posterior pituitary, but the production, the source, is not from the posterior pituitary. It's coming from the hypothalamus. It's a common MCQ, which you are going to find in the papers. So, that's that. Then we have 4 hormones from the anterior pituitary. Of course, we are going to discuss that under endocrine. For now, let's discuss the development. Now, having highlighted the structure of the pituitary gland, we now go to the development. In terms of development, the pituitary gland comes from 2 sources. In terms of germ layer is one germ layer. What germ layer forms the pituitary gland? Ectoderm. Okay, so ectoderm. So ectoderm forms the pituitary gland. But this ectoderm has 2 sources. We have a component from the oral cavity, the mouth, a component from the oral cavity, the roof of the oral cavity. Okay? The roof of the oral cavity forms what we call the Rathketh pouch. Rathketh pouch. Okay? So that's the Rathketh pouch. It's an ectodermal outpocketing from the roof of the oral cavity. It's like a diverticulum. Especially from the oral cavity, or you can call it stomodium. Okay? Yeah. Then the posterior one, the posterior pituitary, forms from the infundibulum, which is basically an extension from the floor of the diencephalon. Floor of the diencephalon. Okay? And it's basically like an extension of the hypothalamus of the brain. Okay? So those are the 2 sources. So it's a downward extension from the floor of the diencephalon. Then they come and meet. Okay? So let me show you the pictures. So we can see in these pictures, okay, we can see the oral cavity and its Rathketh pouch. From the roof of the oral cavity, there is that blind-ended pouch. That is the Rathketh pouch, ectodermal part. Okay, so this one is destined to form the anterior pituitary. Is destined to form the anterior pituitary. Then we can see the infundibulum there, okay, which is just above the Rathketh pouch. We can see there that is the extension that will give rise to the posterior pituitary. So further pictures, we can see B, Now there's reorganization there. Okay, the blue color, you can see it's extending down to form the posterior pituitary. And then you can see the orange color contributing to the formation of the anterior pituitary. But just to help to differentiate the anterior lobe from the middle lobe, meaning the pars distalis from the pars intermedia, there is a green color that has been indicated there for the pars intermedia. Okay, pars intermedia, just to show that this is the middle lobe, but it's also coming from the Rathke pouch. Okay, it's also coming from the Rathke pouch. Now, if you look at this pouch has two walls. WALLS has two walls. There is an anterior wall and a posterior wall. The anterior wall is the one that forms the pars distalis, meaning the anterior lobe, and the pars tuberalis. Alright, the anterior wall forms the pars distalis as well as the pars tuberalis of the anterior pituitary. And it's the one that is well developed. So it develops well, it expands, and forms the biggest lobe, the anterior lobe, and the pars tuberalis. You can see the pars tuberalis or pars infundibularis. The posterior wall of the Rathke pouch does not develop to much of an extent. Okay, so it's slow in development and it doesn't develop much, but just forms a strip-like lobe there, which we call the pars intermedia. Pars intermedia. Even functionally, physiologically, the pars intermedia in a human being has not much significance. Okay, has not much significance. It releases, of course, what we call the melanocyte stimulating hormone, MSH. Okay, but in the human being, that hormone, some authorities say no non-function, but some, of course, say it stimulates melanocytes, okay, to help with the skin pigmentation. Okay, but in other animals, this middle lobe is developed and it contributes to that, to melanocyte stimulation. Okay, but in the human being, it's not clear. The anterior lobe is the one that releases the four hormones I was talking about. Okay, the gonadotropins, LH, FSH, okay, the TSH, and the ACTH. Okay, those hormones. The pars tuberalis also, the pars tuberalis, no hormones from there. No hormones from there. It's just a structure to surround the pituitary stalk. Okay, so that's about the development. Then now you can see that cleft. The cleft that we saw from the previous picture. This cleft is basically a remnant of the Rathke pouch. That cleft for the Rathke pouch. Okay, you can see it's there. There's a white space between the pars distalis and the pars intermediate. That cleft there. Okay, so that's that. So once you know the components of the pituitary gland, it should be easier for you to know the different parts and where they come from. Okay, in terms of embryology. Okay, so questions will be asked. For instance, pars tuberalis, where does it come from in terms of development, and options will be given. So you should know that it's coming from the Rathke pouch. Okay, the oral ectodermal pocket. Okay, the pars distalis and so on. The pars distalis forms 75% of the anterior lobe. 75, three quarters of the anterior lobe, anterior pituitary is pars distalis. Other pictures, you can see how the pituitary develops. Okay, we can see the roof of the mouth, okay, forming right. But I think we have basically come to the end. So maybe just the congenital defects to do with development of the pituitary. You can have a pharyngeal hypophysis. That rat cave pouch, which is supposed to go and form the anterior pituitary, it may remain in the oral cavity. Okay, it may remain in the oral cavity. And then you have a pharyngeal hypophysis, what we call a pharyngeal hypophysis. Okay, then it means those will be problems of the pharyngeal hypophysis inside. Then another common birth problem to do with development of the pituitary are what we call cranial pharyngiomas. Cranial pharyngiomas. You have a pharyngoma in the oral cavity protruding there. Okay, cranial pharyngiomas. Okay, so those are the common things. So pharyngeal hypophysis versus cranial pharyngiomas. You can Google that and see the pictures. Thank you very much.